So, can men get lichen sclerosus on their penis? The answer is a resounding yes.
A very hard yes, absolutely.
Right. But, usually when you think about getting a medical diagnosis, you expect this. I mean, you expect precision.
Right, like it's math or something.
Exactly. You assume medicine is like engineering. You get a weird rash, a specialist takes one look, matches the visual evidence to some textbook, and just hands you a definitive answer.
We really crave that binary clarity in healthcare, But the reality is that the diagnostic landscape for dermatological conditions is, well, it's incredibly murky.
Yeah.
We're dealing with this overlapping web of symptoms where the physical evidence often points specialists in completely the wrong direction, even when the damage is profound and totally visible to the naked eye.
Which is wild. So today, in this deep dive, we are unpacking the stack of clinical guidelines from the British Association of Dermatologists, DermNet, and Patient.info, alongside a genuinely fascinating first-hand account from a patient.
It's a really eye-opening case.
It really is. And our mission today is to understand exactly what male genital lichen sclerosus, or MGLSC, actually is. We're going to examine the physical mechanics behind it, why it is so frequently missed by experienced doctors, and the severe anatomical consequences of just leaving it untreated.
Because the consequences are severe. And to understand the fundamental rules of this condition, we actually need to look at a patient who defied almost all of them.
Right.
His experience just exposes the systemic blind spots in clinical recognition and proves how elusive this diagnosis can be for you or anyone else going through it.
Okay, so let's look at Chris Stanton. He's a 43-year-old writer who, completely out of the blue, develops a painful white ring around the head of his penis.
Yeah.
But before we track his journey, we should clearly define the condition.
Yeah.
Male genital lichen sclerosus, which, by the way, was formerly known by the rather intense name Balanitis serotica obliterans.
Yeah, quite a mouthful. Seriously. But it's an uncommon chronic inflammatory skin condition. And the sources say it has a bimodal peak, meaning it typically strikes in two distinct life phases, either during childhood or later in life for men in their 40s and 50s.
And Chris fits that age demographic perfectly.
Yeah.
He's 43, but his anatomy presents this massive clinical paradox.
Right.
The medical literature is just unambiguous on this point. MGLSC almost exclusively affects uncircumcised men.
And Chris was circumcised at birth.
Exactly. By all standard clinical logic, the statistical probability of him developing the specific localized inflammation was, it was infinitesimal.
So because his presentation didn't fit that classic anatomical mold, the specialists he consulted were just thrown into complete confusion.
Totally baffled.
Right. So he first visits his general practitioner, who looks at this painful developing ring and just casually dismisses it as venous blood.
Which is just, yeah.
Right. Telling Chris it will simply resolve on its own. It's just a staggering dismissal of a localized structural change.
It really is. So knowing something is fundamentally wrong, Chris seeks out a urologist who is entirely baffled and offers zero solutions. And then he eventually secures an appointment with a dermatologist who theorizes it might be vitiligo.
Which I have to say, a diagnosis of vitiligo in this context reveals a really critical misunderstanding of the pathology.
How so?
Well, vitiligo is an autoimmune condition characterized solely by the loss of skin pigment.
Right.
It destroys melanocytes, sure, but it does not cause pain. It doesn't cause structural thinning or physical inflammation. For a dermatologist to suggest vitiligo for a highly painful lesion indicates just how far off the radar MGLSC is for men who don't fit that textbook uncircumcised profile.
Wow. So Chris ultimately bypassed the medical establishment entirely and found his strongest lead by sleuthing on a Reddit forum.
Yeah, doing his own research.
Exactly. He spent hours reading posts that were overwhelmingly written by women dealing with vulvar lichen sclerosus until he found a tiny handful of men describing his exact painful symptoms.
And that's really telling, isn't it?
It is. And it makes me wonder if this condition is so vanishingly rare in circumcised men like Chris, we really have to look at the underlying triggers. He mentioned experiencing other peripheral issues, like numbness and secondary Raynaud disease.
Right.
So my question is, does that suggest this is actually a systemic autoimmune disease and the medical community is just overly fixated on the localized anatomy?
Well, you would naturally draw that conclusion based on his secondary symptoms. And the sources do document a definitive autoimmune link. We see correlations with thyroid disorders, diabetes, and atopic conditions like eczema and asthma.
Okay, so there is a connection.
There is, but the data reveals a sharp divergence between the sexes. Those systemic autoimmune and genetic predispositions are heavily pronounced in women who develop lichen sclerosus.
Interesting.
But in men, while a genetic susceptibility might be lingering in the background, the primary catalyst driving the disease is overwhelmingly mechanical and environmental.
Okay, so if the catalyst in men is environmental, we have to isolate the variable that makes Chris such an extreme outlier. And that variable leads us straight to the anatomical structure of the uncircumcised penis.
Exactly.
The prevailing theory of causation in the literature relies on what we can conceptualize as a micro-greenhouse effect, which is driven by a phenomenon called microincontinence. Can you break that down?
Yeah, so microincontinence is simply the tiny, almost imperceptible amount of urine that dribbles out after a man finishes voiding his bladder.
Right.
For a circumcised man, that residual drop is immediately absorbed by clothing and the skin remains dry. But for an uncircumcised man, that microscopic amount of urine becomes trapped in the mucosal space between the prepuce, the foreskin, and the glans, which is the head of the penis.
Oh, man. So imagine leaving a puddle of highly acidic, concentrated liquid trapped underneath a tightly sealed plastic tarp in the hot sun.
That's a great way to picture it.
Right. If you leave it there for an afternoon, the ground underneath might be perfectly fine. But if you trap that acidic moisture there day after day for years on end, you create a caustic, irritating micro-greenhouse. The environment just simply degrades the underlying surface.
That's exactly what happens. At the cellular level, that constant exposure to urine breaks down the stratum corneum, the outermost protective layer of the skin.
And the body just panics, right?
It does. The body registers this chronic irritation as a persistent attack and initiates a profound inflammatory cascade. Immune cells just flood the area.
Yeah.
They release cytokines that cause a hyperproliferation of certain skin cells while simultaneously thinning out others. The tissue is caught in this endless loop of injury and panicked repair.
And that physiological panic is actually amplified by everyday movement, isn't it? The sources detail a phenomenon known as the Koebner response.
Yes, the Koebner response.
Yeah. Right. When the skin is already inflamed from the trapped urine, any secondary mechanical friction, whether that's from tight clothing, athletic movement, or sexual activity, acts as an accelerant. The immune system overreacts to the physical friction, treats it as further trauma, and deploys even more inflammatory cells to the site.
It's a vicious cycle. And we also need to delineate the boundaries of this condition to counter the rampant misinformation surrounding it.
Definitely.
Lichen sclerosus is not an infection of any kind.
Right. Not an infection.
It is absolutely not a byproduct of poor hygiene. In fact, patients who overwash the area with harsh alkaline soaps in an attempt to clear up the inflammation, they actually strip away the skin's natural lipid barrier and drastically worsen the condition.
Oh, that's tragic. You try to clean it and make it worse.
Exactly. Furthermore, it is not a sexually transmitted disease and it cannot be passed to a partner under any circumstances.
Good to know.
We do, however, see a strong statistical association in men with increased BMI and smoking.
Why is that?
Well, a higher BMI can exacerbate the anatomical occlusion and trapping of moisture. And smoking induces severe vasoconstriction, so it narrows the blood vessels and impairs the skin's ability to heal from that inflammatory cascade we talked about.
Makes sense. So because this relentless inflammatory loop fundamentally alters the cellular architecture of the skin, the resulting physical symptoms mimic a variety of other conditions, creating an absolute diagnostic minefield.
A total minefield. The presentation is a chameleon.
Yeah. Patients can experience a spectrum ranging from completely silent progression, where they feel no pain at all, to intensely debilitating agony.
We are talking about severe pruritus or itchiness, burning sensations, and painful erections.
And the medical term, dyspareunia, painful intercourse, is heavily cited here too, right? Because the compromised skin loses its elasticity and can literally tear and bleed under tension.
Yeah, the physical reality is brutal. Visually, the early stages are highly nonspecific. A physician examining the patient might only see generalized erythema redness or tiny microfissures and scattered bleeding points.
So it's easy to dismiss early on.
Very easy. Occasionally, small hemorrhagic blisters form under the surface, but as the chronic inflammation persists, the hallmark sign emerges. The skin loses its pigment, turning stark white, and becomes visibly thinned out, taking on a texture frequently compared to crinkled cigarette paper.
And the loss of pigment and the crinkled texture are just the superficial changes. The true devastation of MGLSC lies in the structural deformities.
That's where things get really serious.
Yeah, when the body constantly attacks and attempts to repair the same tissue, the fibroblasts, which are the cells responsible for generating connective tissue, they go into hyperdrive. They stop producing supple elastic tissue and start laying down dense, rigid collagen. This creates irreversible scarring that physically reshapes the anatomy.
And the clinical terms for these structural changes are severe. The literature describes wasting, where the fibrotic scar tissue forms a tight, unyielding band around the shaft of the penis, creating a literal hourglass constriction.
Oh, wow.
Yeah. Patients develop profound phimosis, rendering the foreskin completely incapable of retracting due to the rigid collagen ring.
That sounds awful.
It is. The scarring can even engulf the meatus, the urinary opening, narrowing it so drastically that patients experience severe urinary spraying or an inability to void completely.
Okay, so when a patient presents with redness, microfissures, or early white patches, you can completely understand why a general practitioner might misdiagnose it as a stubborn fungal infection, like thrush, or a general inflammation, like Zune balanitis.
Right. It looks like a lot of other things at first.
But realistically, if a patient is presenting with wasting, where the pliable tissue has literally been replaced by a rigid ring of scar tissue, no simple visual inspection is going to untangle the root cause, which raises a massive contradiction in the clinical guidelines.
Oh, the biopsy issue.
Exactly. Why do the medical sources explicitly warn against relying on a biopsy? Taking a tissue sample and examining it under a microscope is universally considered the gold standard for solving dermatological mysteries.
It is, usually. But the guidelines highlight a fascinating and dangerous paradox within pathology here. A biopsy for lichen sclerosus frequently sends the medical team down a false trail.
How does that happen?
Well, if a doctor biopsies the tissue during the early, subtle stages of the disease, the microscopic analysis will simply reveal nonspecific inflammatory cells. The pathologist's report will effectively say, the tissue is inflamed, which provides zero diagnostic clarity to the treating physician.
Right. And if they wait until the structural scarring is severe?
If the disease has progressed to obvious white patches and fibrotic wasting, the biopsy merely confirms what a trained specialist can already see with the naked eye. But the real danger lies in the specific cellular makeup of severe lesions.
Okay, what do you mean?
A biopsy of an advanced MGLSE patch often reveals a heavy infiltrate of plasma cells, which pathologists refer to as zoonoid inflammation.
So the pathology report actively misdirects the diagnosis.
Precisely. The pathologist identifies the zoonoid inflammation and formally diagnoses the patient with Zune balanitis. The entire medical team is immediately distracted from the true culprit. They prescribe treatments for Zune balanitis, the lichen sclerosus goes unchecked, and the tissue continues to degrade. According to the nThat guidelines, a biopsy is genuinely only useful to rule out malignancy or if a specific lesion completely refuses to respond to aggressive treatment.
That is wild. The stakes of these misdiagnoses are incredibly high. If a doctor dismisses it as a fungal infection or a biopsy misleads them towards Zune balanitis, the patient is left without the necessary intervention.
And time is tissue here.
Right. Leaving male genital lichen sclerosus unmanaged goes far beyond chronic discomfort. It initiates a cascade of dangerous anatomical failures. We mentioned the rigid scarring of phimosis, but that can easily escalate into paraphimosis.
Which is an absolute emergency.
Yeah, it's a severe urological emergency where the scarred, inelastic foreskin is forcibly retracted and becomes trapped behind the head of the penis, acting like a tourniquet that cuts off blood circulation to the tissue.
And the fibrotic scarring doesn't just remain on the exterior surface either. The inflammation can travel down into the urethra itself, creating dense urethral strictures.
So it's blocking things internally.
Exactly. The scar tissue acts as a dam, blocking the flow of urine so severely that patients require complex, invasive reconstructive surgery, known as a urethroplasty, simply to restore basic urinary function. But the most alarming complication hovering over unmanaged MGLSE is the explicit link to oncology.
Yeah, the statistics surrounding the cancer risk demand serious attention. The clinical sources state that 1/3 to 1/2 of all penile cancers are directly associated with the background of lichen sclerosus.
It is a sobering metric. To maintain perspective, though, the overall lifetime risk for an individual patient with MGLSE developing squamous cell carcinoma is estimated at about 4 to 5%.
Okay, so 4 to 5%.
Right, so the individual incidence rate is relatively low. However, because penile cancer is an exceptionally rare malignancy in the general population, the fact that up to 50% of all cases originate in tissue ravaged by lichen sclerosus illustrates the destructive power of chronic inflammation.
That's a huge proportion.
It really is. Years of unchecked inflammatory response forced the cells into an unnatural state of constant, rapid turnover. That hyperproliferation drastically increases the mathematical probability of DNA transcription errors, which is the foundational mechanism of cancer.
So knowing the severity of the urethral damage and the oncological risks, the treatment protocol has to be aggressive.
Very aggressive.
The absolute first-line defense is an ultra-potent topical steroid, specifically clobetasol propionate. And the mechanism of action is crucial here. The steroid molecules penetrate the cell membranes and literally bind to the receptors that control inflammation, switching off the genes that produce the inflammatory cytokines.
Right, it stops the fibroblasts from producing more rigid collagen?
Exactly. But accessing this treatment forces the patient to navigate a massive psychological hurdle at the pharmacy.
You're referring to the pharmaceutical packaging, right?
Yes. When a patient picks up this ultra-potent steroid cream, they are met with a massive, bold warning printed on the box, and the tube itself that explicitly mandates "do not use on genital skin."
Yeah, it's right there in bold letters.
Imagine the cognitive dissonance for a patient. You're already dealing with a terrifying, painful, potentially precancerous condition on your most sensitive anatomy, and the medication handed to you comes with a blaring warning that you are about to do something dangerous.
It requires an immense amount of trust in the specialist. The British Association of Dermatologists guidelines are unequivocal on this issue. Patients must entirely ignore the manufacturer's warning.
Just ignore it completely.
Completely. Dermatologists confirm it is clinically safe and absolutely vital to deploy this ultra-potent steroid directly onto the genital mucosa to arrest the immune system's destruction of the tissue.
And what's the timeline on that?
The standard protocol requires daily application for a month to suppress the acute flare, followed by a slow, methodical tapering process.
Okay, so once the acute fire is extinguished by the steroids, the patient enters a lifelong maintenance phase. The goal shifts from suppressing the immune system to physically protecting the skin from the environmental triggers, specifically the micro-greenhouse of trapped urine we talked about.
Right. It becomes all about barrier protection.
Patients must abandon traditional alkaline soaps, which strip the protective lipid barrier, and transition entirely to gentle soap substitutes. Furthermore, they're instructed to apply heavy barrier creams, like basic yellow soft paraffin or thick emollients. The objective is to essentially waterproof the tissue, creating a physical shield so the residual urine cannot chemically burn the stratum corneum.
But the daily application of these thick, oil-based emollients introduces a genuinely bizarre yet critical safety hazard that patients must be warned about.
This part blew my mind. The British Skin Foundation actually issues an official fire warning for patients utilizing these barrier creams.
Yeah, a literal fire hazard.
Because the emollients are heavily oil-based, they inevitably soak into the patient's underwear, their trousers, and their bed linen. And even after the ointment dries, and crucially, even after the fabrics have gone through a high-temperature cycle in the washing machine, the microscopic oil residue remains permanently bonded to the cotton fibers.
The physics of the fabric are fundamentally altered at that point.
Wow.
The embedded oils drastically lower the flash point of the material, transforming everyday clothing into a severe fire hazard. If a patient wearing emollient-soaked clothing comes into close proximity to a naked flame like a gas stovetop, a space heater, or a lit cigarette, the fabric can ignite with terrifying speed and intensity.
You are essentially turning your cotton underwear into the wick of a candle.
Exactly.
You are systematically waxing your clothing to catch fire. It is a completely surreal, unexpected consequence of attempting to manage a localized skin condition. It highlights exactly why this cannot be managed through internet sleuthing alone.
No, definitely not.
You need a dedicated specialist to look you in the eye, validate your symptoms, tell you to ignore the terrifying warning on the steroid tube, and then casually advise you to stay away from open flames because your pants might combust.
It's a lot for a patient to process. But for 30 to 40% of patients, the topical steroids and the diligent emollient routines are not enough to halt the disease progression, or the fibrotic scarring is already too advanced when they finally receive an accurate diagnosis.
So what happens then?
When the medical route fails, the definitive surgical intervention is circumcision.
Which highlights the immense anomaly of Chris Stanton's initial presentation. He was already circumcised, yet still developed the disease.
Right, making him a statistical outlier.
But for the vast majority of men, circumcision offers a permanent cure.
The surgical logic is pretty straightforward. By amputating the prepuce, the surgeon completely eradicates the mucosal environment.
So there's no more micro-greenhouse.
Exactly. There is no longer a physical space for the microincontinence to become occluded. The micro-greenhouse is dismantled. Following a successful circumcision, the localized inflammation ceases, the risk of developing deep urethral strictures vanishes, and the elevated risk of squamous cell carcinoma plummets back toward baseline.
That's incredible.
Patients still require ongoing self-examination, but the surgical removal of the environment is highly curative for the majority of uncircumcised sufferers.
Well, let's synthesize the scope of this condition. Can men get lichen sclerosus on their penis?
Yes.
They absolutely can. It is primarily driven by a highly localized mechanical trapping of moisture and friction. It operates as a clinical chameleon, mimicking fungal infections and leveraging complex cellular infiltrates to actively trick pathologists analyzing biopsies.
Right.
It requires the application of ultrapotent steroids that contradict their own warning labels, demands the constant use of highly flammable barrier creams, and often culminates in surgical amputation of the foreskin. Above all else, it demands relentless self-advocacy from the patient.
That's the real takeaway here.
If Chris Stanton hadn't spent hours analyzing women's health forums on Reddit, if he had simply accepted his doctor's dismissal that a painful white ring was just venous blood, he could have easily progressed to irreversible fibrotic scarring or a pre-cancerous state.
His story is a powerful reminder of the physical complexity of the human body and the inherent rigidity of clinical expectations. When a condition defies the standard demographic profile, even the most visually obvious structural destruction can remain entirely unseen by a sequence of highly trained specialists.
Which leaves you with a deeply unsettling question to consider. If a disease capable of replacing pliable tissue with rigid bands of scar collagen, literally altering the physical architecture of the human anatomy, can go completely unrecognized by multiple doctors simply because the patient didn't fit the expected mold, what other profound, structurally obvious conditions are currently hiding in our medical blind spots, just waiting for an isolated patient to finally connect the dots on an internet message board? Keep digging.